Hello, everybody. My name is Andreas Hochhaus from the University Hospital in Jena in Germany, and I would like to review the European Leukemia Net recommendations on the management of chronic myeloid leukemia and how they have evolved over the last 15 years. Actually, the first recommendations on the management of CML appeared back in 1999. And these recommendations were initiated by the American Society of Hematology. And the American colleagues invited European experts to participate in the publication of these evidence-based analysis of the effect of chemotherapy, interferon alpha, and allogeneic bone marrow transplantation in the treatment of CML. However, only 2 years later, in 2001, these recommendations were already outdated because imatinib was registered. And as we all know, this was a revolution in the treatment of CML with the tyrosine kinase inhibitors, starting with imatinib and then later with other inhibitors. This was a major change in the treatment of CML because the outcome of patients improved significantly. We have now a 10-year survival with imatinib of 83%, consistent in many studies. Here as an example, the CML4 study from the German CML study group, but also in the IRIS study, which was the pivotal study for first-line treatment, the 10-year survival was 83%, much better than with interferon, with stem cell transplantation, and with chemotherapy. And this new experience, of course, was needed to be implemented in the recommendations, and the European Leukemia Net started a series of recommendations in 2006 with the evolving concepts in the management of CML. And the next one appeared in 2009, and then later in 2013. With the evolution of the knowledge, with the evolution of new inhibitors on the market, and with the evolution of the monitoring strategies, most importantly, the development and standardization of quantitative polymerase chain reaction for the monitoring of CML patients. And the most recent recommendations were published in 2020 in leukemia, in the journal Leukemia. It's important to know that this was based on a discussion between these 34 experts from Europe, America, and the Asian Pacific region. The panel met 6 times, and 5 sets of questionnaires were sent around, and the aim was to achieve a 75 to 100% consensus of all major issues in the management of CML. If this was not achieved, this is mentioned in the publication. The cost of these meetings were completely covered by the European Leukemia Net without involvement of the pharma industry. Here's the evolution of the different aspects of the recommendations, and I'm grateful to Gian Antonio Rosti, who put this slide together. The first-line treatment was, as mentioned, in 2006, imatinib. Later, in 2013, we had 3 drugs available for the first-line treatment. Now, in 2020, we have 4 drugs: imatinib, nilotinib, dasatinib, and bosutinib. I will later discuss how we choose the different drugs for the first-line treatment of CML. A second-line inhibitor was not available in 2006. We had the option to increase the dose of imatinib to 600 or 800 milligram, but also to change treatment to chemotherapy or to use allogeneic stem cell transplantation or interferon in case of relapse resistance to imatinib. The milestone, the most important milestone for the treatment of CML was at that time complete cytogenetic remission. The monitoring was based on cytogenetics. During the IRIS study, the standardization of quantitative PCR was developed, and with the standardization worldwide, the molecular response became more and more the goal, the aim of the treatment, the milestone, and also the quantification of the molecular response was important. And in the IRIS study, the major molecular response was defined as the major milestone for the treatment with tyrosine kinase inhibitors. And this is, of course, reflected in the evolution of the recommendations. Now we have a new goal of our treatment, that's deep molecular response. This means a response level which is a trigger for treatment discontinuation to achieve treatment-free remission. The salvage treatment used to be allogeneic stem cell transplantation. Now, of course, with the new drugs, we have other salvage treatments available, but allogeneic stem cell transplantation is still an important factor for a minority of CML patients who have a poor biological background of their disease, but also with resistances or with a lack of normal hematopoiesis. These are all factors which may be the background for the consideration of allogeneic stem cell transplantation. More complicated is now a second or third line treatment with now 5 drugs available in most countries, in some countries also alternative drugs. We have now the option to shift treatment according to the biology of the CML, according to the mutations, the BCR-ABL mutations which may appear, and other factors. The last point in the discussion are the concerns of the treatment. Here, the concerns were in 2006, a short follow-up and the emerging mutations. It was expected that most, if not all patients, get mutations over the years, which is fortunately enough not the case. That means a patient in good molecular response is on the safe side. The emerging mutations are not the issue anymore. But our current issue, our current problem, are the long-term side effects to the tyrosine kinase inhibitors. Therefore, the option of treatment-free remission might be very important, not only for cost issues, but also for the well-being of the CML patients and the lack of major side effects over the years of therapy. In the 2020 recommendations, there's a list of different topics which are covered: the risk status, newer TKIs, shared decision-making, very important, the discussion between the doctors and the patients on the first line and second line treatments, the monitoring, the option for treatment-free remission, which is also, of course, based on a discussion between the physicians and the patients, the management and of adverse events and how to avoid adverse events, family planning, and of course the cost issue for the society, but also for the individual patients. The diagnostic workup has been described in the recommendations. It's still important at diagnosis to do a complete blood cell count with a microscopic differential, not with an automatic differential, because the microscopic view is much better in the individual distinction between blasts and non-blasts and other cells. A bone marrow aspirate is still standard of care because we need it for the cytologic examination, the number of blasts, basophils and eosinophils, but also to perform cytogenetics. A core biopsy is not needed in all patients, only if we have a dry tap with the bone marrow aspirates. Some pathologists claim that the core biopsy at diagnosis is advantageous because we can detect the fibrosis, which has an unfavorable outcome, but this was not consensus between the experts in the discussions. A chromosome bending analysis is needed at diagnosis. The FISH analysis is only needed if we see a pH negative patient and if we need a second confirmation on the BCR-ABL status apart from polymerase chain reaction. We need a qualitative RT-PCR for the detection of the type of the BCR-ABL transcripts. We don't need a quantification at diagnosis. This was not consensus as well. We need an ECG for the QT time, and we need the standard biochemical profile with the hepatitis B serology, because some of the tyrosine kinase inhibitors may be immune suppressive and induce relapse of hepatitis B. What about prognosis? In 1984, Joseph Sokal published a score which is based on age, spleen size, blast cell count in the peripheral blood, and platelets with the endpoint of survival on chemotherapy, because no other treatments were available. Over the years, other parameters were added. Eosinophils and basophils were detected routinely later in the 90s, and therefore added to the Hasford score. In the era of tyrosine kinase inhibitors, the survival was difficult to observe, because the good outcome of CML patients and the short follow-up was not able to use the survival as an endpoint. Therefore, complete cytogenetic response was added here, and only spleen size and basophils were parameters to predict the chance to achieve complete cytogenetic remission. Age was not a factor anymore, because this was not based on the overall survival. But now, with longer follow-up of the use of tyrosine kinase inhibitors, we were able to use survival again as an outcome, but restricted to CML-related deaths. And with this endpoint, and with imatinib as the major therapy for this UTOS long-term survival score, age, spleen size, blasts, and platelets are again the most important parameters for the prediction of the outcome of our patients. The same parameters as in 1984, but with a different formula here to calculate the chance of response. But this means that these are really robust parameters for the prediction of outcome of CML patients. However, we have, in addition to these clinical parameters, other parameters which may predict a high-risk disease, and these are very specific additional chromosomal aberrations in the Ph-positive clone, like trisomy 8, derivative 3, 7, 17, 19, and 21, and also a second Philadelphia chromosome. This cytogenetic chart here shows the trisomy 8 in addition to the 922 translocation. This is an example for a high-risk patient based on the initial cytogenetics at diagnosis. And this clearly demonstrates the need for cytogenetics at diagnosis. The pink curves demonstrates the patients with these high-risk aberrations compared to all other patients. And you see a clear difference for survival. And some of these patients, if not all, may be candidates for an early allogeneic stem cell transplantation. It's a minority, but a very important minority for the long-term outcome of these patients. And we have mutations. We have mutations outside of BCR-ABL, most importantly A6L1, but also DNMT3A and other mutations. Here in this chart, you see mutations at diagnosis. We detected in 100 patients in the TIGER trial, mutations in 26% of patients at diagnosis. And we now know, with a longer follow-up, that A6L1 at least is a marker for a reduced chance to achieve a major molecular response on treatment. But since this information is very new and not a consensus in all countries worldwide, this was not implemented in the recommendations, but I'm sure that in the next version of the ELN recommendations, these molecular aberrations will be important. And it's of course very important to exchange information worldwide. And this is a major basis for the Global Genomic Alliance, which has been initiated by the International CML Foundation. We have now 6 drugs available. One is not registered, not yet registered. The other drugs are depicted here. These are dendrograms for the inhibition of the different enzymes in the cell. And you see a multi-kinase inhibition here for several drugs like dasatinib, ponatinib, and bosutinib, and the more stringent inhibition for nilotinib and imatinib. The size of these bubbles here demonstrate the power of inhibition for the different kinases. The multi-kinase inhibition may be advantageous for an clonal evolution of CML, the activation of BCR-ABL independent pathways, and the more restricted inhibition may be advantageous when we look at side effects to these specific drugs. So survival is not different over long term now for first generation drug like, or the first generation is imatinib, and second generation drugs like dasatinib, nilotinib, and bosutinib. However, we see a major difference for the achievement of the molecular response levels with second generation drugs versus imatinib. Not only the likelihood of achieving a major molecular response by 5 years, but also the deep molecular response, which is the trigger for treatment-free remission, and also early molecular response at 3 months. However, we see very specific side effects with these specific drugs. This is the example here of nilotinib versus imatinib in the NSND trial. The concern is the development of cardiovascular side effects over the years. This is a linear curve. That means there's an accumulation of cardiovascular side effects over years. My conclusion out of this is, and this is also reflected in the ELN recommendations, if a patient was not able to achieve treatment-free remission after 5 years of nilotinib treatment, I would change the treatment to avoid the risk for additional side effects over years, because even in the Framingham low-risk cohort, we see higher likelihood of cardiovascular events with nilotinib versus imatinib. That means nilotinib, in conclusion, is a very good drug to achieve a treatment-free remission, a deep molecular response with consecutive treatment-free remission. But if this is not achieved, a change might be considered. But also very important is the analysis of the comorbidities and the risk for cardiovascular side effects by patient information like smoking status, like age, like cholesterol level, and blood pressure. If you have a patient with several risk factors here, it might not be the ideal candidate for nilotinib treatment, whereas other patients with a good blood pressure, with low cholesterol, and also women versus men and non-smokers versus smokers are very good candidates for a second generation drug and very good candidates for nilotinib. The molecular assessment was already mentioned, and based on several studies, we have now defined milestones over the initial months in the first year, and also overall milestones which demonstrate optimal response. That means we don't need to change the treatment, and failures. That means treatment should be changed immediately because the outcome of continuous treatment with the same drug may be unfavorable. And we have in between a warning category where we need to observe the patient more carefully. And for patients aiming TFR, the optimal response is not only the major molecular response as mentioned, but the deep molecular response, because with deep molecular response, we can discontinue therapy. And new in the most recent ELN recommendations is the strict requirement to change treatment if 10% BCR-ABL was not reached after 3 months of therapy. We need a confirmation with a second test, but we don't need to wait longer until we change therapy. And we have, in addition to the overall recommendations, we have an evolution of the recommendations for CML monitoring. As mentioned back in 2006, the quantification was developed and standardized, and this was published in Blood in 2006, and later the recommendations for kinase domain mutation analysis was published, and then later the standardization of molecular response for the global use, and also recommendations for scoring deep molecular responses for treatment discontinuation. And this is demonstrated here. We defined major molecular response and the deep molecular response levels independent from the local assay used and independent from the platform on which the analysis is done. With the introduction of the conversion factor, we were able to compare data globally all over the world in different countries. And also for deep molecular response, we needed to define the sensitivity of the analysis, and this is done by threshold levels for the control genes, here in this case published in the ELN recommendations, ABL and GAS-B levels. For the choice of the initial tyrosine kinase inhibitors, we need to consider the goals of treatment. If treatment-free remission is the goal for younger patients with family planning and or with comorbidities, we should consider a second-generation drug because we achieve a faster response. The clinical and biological risk should be considered, and also comorbidities with risk of adverse events and the availability of drug and of reimbursement in the individual country. And this should be done with shared decision-making. That means the patient should be well informed about the status of the development of the drugs, the status of potential side effects, and of course, on the efficacies. And it's important to recognize that all TKIs have toxicities. I mentioned nilotinib, but also all the other drugs have long-term toxicities, which may cause clinically relevant complications. We have arterial vascular disease with nilotinib and ponatinib. We have respiratory failure and pleural effusions with dasatinib, and we have long-term renal impairment with imatinib, and all this should be considered when we select the individual drug for the individual patient. We have a good chance to optimize treatment in second line and even in third line when we observe a relapse or the non-optimal response in the first-line therapy. And we can, of course, change treatment with all the drugs available. This graph shows the changing of therapy from first line to second line and third line, but we must not forget the use of allogeneic stem cell transplantation if we have indication for a biologically aggressive disease and for a lack of normal hematopoiesis. For treatment beyond second line, the transcript level of 1% is our goal of therapy, not major molecular response, because we know that this cannot achieve in the majority of patients with third line therapy. And we know, on the other hand, that the 1% level is the safe side for a third line treatment. If we tried the use of 2 or more TKIs, allogeneic stem cell transplantation should be considered, and the treatment change should be based on the BCR-ABL mutations which should be detected in case of relapse or non-response. In Europe, we currently transplant more patients in advanced disease as compared to early chronic phase. This is a negative development in the last 10 years, because this minority of patients who needs to be transplanted has an advantage when the transplantation takes place in chronic phase. This is depicted here, the light blue curve, chronic phase patients, the other curves, later stages of the CML, and the outcome of allogeneic transplantation clearly depends on the start of transplant in early chronic phase or in chronic phase. Another problem is the optimal dose of treatment. Here you see the initial approval for frontline and salvage treatment, and you see how the dose developed over the years. I mentioned the high-dose imatinib for patients who tolerate the drugs but did not achieve an optimal response. Dasatinib has the risk of pleural effusions, and we know that the tolerability is better with a lower dose. Studies have been performed with 50 milligrams of the drugs. In Germany, we perform a study with 5 days per week for dasatinib, which is an option since we know that dasatinib has a very short half-life. Starting with 800 milligrams nilotinib in the development of the drugs, we now know that 300 is much better tolerated and now is the standard of care for first-line treatment. The same for bosutinib. 400 has advantages over 500, and ponatinib has a wide range of different dosages. With 45 milligrams, cardiovascular events were very frequent, with more than 20%, and therefore studies were performed trying to reduce the dose in case of molecular response and to start with a low dose. The low dose start is disadvantageous. The efficacy is lower than with the higher dose. Therefore, the recommendation is now to start with 45 milligrams and to reduce the dose in case of molecular response. The only exceptions are patients with cardiovascular comorbidities. Here, a compromise might be to start with 30 milligrams and then to reduce the dose to 15. Another point is the already mentioned chance to achieve treatment-free remission. We know now from several thousand patients who were discontinued in case of deep molecular response that the average chance to have a long-term treatment-free remission is about 50% across different trials. And we developed requirements in the ELN recommendations, which are mandatory. And the most important requirement is, of course, the agreement and the motivation of the CML patient, but also the availability of a high-quality quantitative PCR to select the patients in deep molecular response, but also to follow up these patients. Minimal requirements are the typical BCR-ABL transcripts, which can be quantified over the years, and the duration of the deep molecular response of more than 2 years, and the duration of overall TKI therapy of more than 5 years and 4 years in case of second-generation TKI. And there are optimal requirements. That's a new introduction into our recommendations. The optimal requirements means we recommend the treatment-free remission because the risk of long-term side effects is much higher than the risk for an attempt for treatment-free remission. And this is a duration of TKI therapy of more than 5 years, duration of DMR of more than 3 years if it's MR4, or more than 2 years if it's MR 4.5. And we have, of course, mentioned in the recommendation that the development of drugs and knowledge is not done. We have new options. We have now asciminib as another tyrosine kinase inhibitors with a very specific aim of action, the so-called myristoyl binding site inhibition. It will be registered for third line or later lines of therapies, but first-line studies are already ongoing. And we improve the chance for treatment-free remission with maintenance therapies targeting persisting stem cells or their environment. That means introduction of an immune response or the targeting of BCR-ABL independent pathways. With this overall evolution of the ELN recommendations and other recommendations, I would like to acknowledge the participation of the panel members and also the participation of, most importantly, Nick Cross and Sue Brantford for the recommendations for molecular monitoring. thank you very much for your interest in this work.